is The Essential Physics of Medical Imaging, and so I'll lean on this book to take figures and explanations for the underlying engineering and physics of the imaging techniques we're going to look at. So most of the slides, if they're not attributed, they come from this book, Essential Physics of Medical Imaging. Okay? And you're welcome to rent that or buy it, or if you really like medical imaging, this is kind of everybody has this book on their shelf if they're in medical imaging. It's a standard classic textbook. They're in the 3rd edition at this point. So those are the sources of, if you don't, otherwise, like if I have a picture up and it's of a movie or something and it's not from one of those 2 sources, I'll attribute it at the bottom with text and you can go find the original source. Okay. So any questions thus far? No. Okay. Just let me take a quick survey. How many people are in bioengineering? How many in electrical engineering? 1, 2, 3, and other, I guess. You guys are other. Okay, terrific. All right. So here's basically a quick display of virtually all the imaging techniques we'll look at. And in the top left corner, up here, this is just a cartoon of a heart, and this segment of the heart is the muscle in the left ventricle which pumps blood to the whole body. And what is essentially depicted here in a blue color is a region of the left ventricle that is not getting enough blood flow. And the reason it is not getting enough blood flow is there is a stenosis, or a narrowing of the primary coronary artery that is feeding that section of tissue. So if that artery gets narrow, essentially what happens is you limit the amount of flow that can get through that artery. And then if you put demand on the tissue, like you run for the bus or something like that, and you need more blood flow and you don't get enough, you will get ischemia in this region. That's the primary sort of disease called cardiovascular disease, is ischemic damage to tissue because the blood flow is not getting there. With that ischemia comes classic symptoms like chest pain, nausea, you start getting sweats, you start feeling a tightness in your chest, and then sometimes a radiating pain down your arm and down your leg. So when you reach middle age, everyone is trained to recognize those symptoms, because when you have those symptoms, you're in this condition and you should go to the hospital, right? What they'll do at the hospital is they'll actually sort of confirm that the vessel itself is narrowed, and then they'll go in there and they'll open it, right, to restore the flow. And they can open it in a number of ways. They can do bypass surgery if it's very severe, or they can put a stent in that vessel and open it up so you get flow again. So most people these days that get to the hospital survive their heart attack, right? That's, survival of a heart attack is pretty common now. But about 30% of people, the first symptom that they display that they have this disease in their vessels in their heart is that they are dead. They just fall down and they die. It's called sudden death. And people are jogging and they just go, whoop, boom, and just fall down and die. And that is, they get a major occlusion of a vessel that causes very abrupt ischemia. And then that causes electrical abnormalities in the tissue. And then all hell breaks loose, right? So they get ventricular fibrillation. The coordination of the electrical activity goes off. And so their heart stops pumping. They're alive, but they pass out within about, 2 seconds, something like that. And then they die because their heart isn't pumping, right? It's called sudden death. And, it happens to a lot of people, right? And the way to prevent sudden death is to know that you have cardiovascular disease, right? If you have no symptoms, that doesn't mean you don't have cardiovascular disease. That just means you don't have symptoms, right? Your vessels could be full of all these stenotic lesions and things. So we'll talk about that a bit and how you would screen for that. Although it's remarkably at this time, it is not recommended to screen for cardiovascular disease, even though so many people die suddenly. And we'll talk about that a bit. Basically because it leads to too much, they claim, too much downstream care. It's an economic decision, but anyway, we'll talk about that later. So this is a CT scan of coronary vessels, right? This scan gives very nice depiction of those vessels and the heart itself. This is an example of echocardiography of the heart, and this is, we'll look at the pictures of a transducer is held by the operator, and then you look at the chambers of the heart using reflected sound waves up in the 20 megahertz range. This is nuclear medicine. They're called single photon emission computed tomography, SPECT. Tens of millions of these are done every year. It took off in the 80s and 90s and 2000s, just kept growing in terms of the number of studies that were done. And this is an MRI image of a patient's chest. And in order to make a clear picture of the heart, you have to take the EKG and gate your acquisition such that it's always taken at the same phase of the heartbeat, because you need multiple heartbeats to make a picture. And then this is X-ray angiography, in which the patient lies down on a table, you inject dye into the arteries, and you take these pictures. These pictures are super clear because they're obtained in like 3 milliseconds each. Like the shutter speed of this camera that does this is about 3 milliseconds. It's very, very quick. Whereas the shutter speed of this is minutes. This is, tens of milliseconds or something. So, or maybe 5 milliseconds. So we'll go through each of these so that you get a feeling for what you're going to see in a class in terms of whether or not you actually want to understand these techniques or not. So when you look at imaging, there's a couple of things you have to, in order to understand what the imaging method is capable of seeing, you quantify the image quality with a few metrics. And one is sort of how long does it take an image, imaging time. Voxel dimension is how big is the volume for each individual estimate in that 3D image. And then basically the display frame rate is usually tied to the temporal resolution of the imaging technique itself. So if you have a very high temporal resolution, you'll have a high frame rate. But sometimes you can get a high frame rate by pooling data from multiple heartbeats, as we'll see with MR. But this is a starter table for the relative values of these parameters. And so here, 2D echocardiography, imaging time is, down to 30 milliseconds per picture. 3D echocardiography is about 3 seconds per picture because you have to add up a whole bunch of views to get a 3D volume. Nuclear medicine, many minutes to take the image that you're going to look at. Computed tomography, right now it's about 150 milliseconds to take that full 3D volume, which is pretty remarkable when we take a look at the other parameters, such as the size of the voxel. 2D MR, about 12 seconds. 3D, about 3 minutes to take a full 3D volume with decent signal to noise. X-ray angiography, I say here 70 milliseconds, but it's actually, the frame rate is 15 to 30 frames a second, but the actual pictures are taken at a much higher or a narrower window. It's like the shutter speed on your camera. All you guys just have phones for cameras. Like nobody has a camera, right? An actual camera. Who has a camera? Raise your hand. Okay, so you know what the f-stop and shutter speed and all that kind of business is, right? So when you you lengthen the shutter speed to get more photons in, to get better dark, field imaging, basically, things blur. So people move and you see a blur, right? And so we're susceptible to that in cardiovascular imaging too, this motion blur. And so if you can take your data really quickly, you can eliminate that blur. But if you look at the voxel dimensions of some of these, it's pretty interesting. So 2D echocardiography, it's like a 3 millimeter by 3 millimeter by 3 millimeter voxel. So when you take a look at the picture, it's a set of boxes of signal intensity, and this is the dimension of each box. So if you think of it in terms of 3D, it's like a Lego structure, and it's the dimension of the Lego bricks you're making or you're using to construct that thing, right? So if I have a Lego model here of a gnome, and I use tiny little Lego pieces, I'll get a much higher resolution picture of a gnome when I come over here and have Lego pieces that are big blocks, right? So the pieces we're using are of these dimensions. Nuclear medicine, you can see it's like 1 centimeter by 1 centimeter by 1 centimeter. They're big blocks, right? So the heart itself is only about 10 centimeters across, right? So these are big blocks compared to the size of the heart. But in nuclear medicine, what you're really trying to measure is blood flow, as we'll see, and so maybe that's okay to have a big chunk of tissue and estimate the blood flow in that chunk. Computed tomography has a remarkable voxel dimension of 0.4 by 0.4 by 0.625 millimeters. So just think about that a second. Like that's half a millimeter on a side, right? That's a tiny voxel. If you tried to make a 3D MR picture with voxels that big, you'd be there all day. It would take you hours and hours and hours of averaging data to get enough signal to noise to do it. But remarkably, computed tomography does it in about 150 milliseconds. Takes the data. 2D MR, we're talking about 1 millimeter by 2 millimeters by 7. So the slice thickness is usually around 7 millimeters. And then the in-plane resolution is usually 1 by 2. For 3D, you take a bit more time and make the slice thinner. And then X-ray angiography, the claim is that it's 0.15 by 0.15 millimeters in plane, and then through plane, it's actually a projection of the whole darn object. But we'll see why you can deal with that. You inject contrast just to project things. Okay, so we'll return to this table when we're actually doing the imaging, and we'll maybe update some of these values as we get more experience. So echocardiography looks like this. Has anybody had an echo exam in their life for whatever reason, like your kidney, liver, or whatever? You probably not your heart at this age. Well, exams look identical. Like this woman is looking at his liver by the looks of it as a vessel there on the screen. That thing here. This transducer sends sound waves into the patient and then listens for reflected sound waves back from the patient. So it both, emits and then receives sound waves. And based on the echoes that it hears, right, that the system hears, it constructs a picture of where those major echoes are coming from, the distance away from the transducer that they're coming from. And if she were to tilt this and point it up towards the heart, she would see the heart. So it's basically where you are imaging is absolutely controlled by how you point the transducer. And it's a fantastic imaging technique for cardiac, in the sense that if you've got somebody in the ER and they're like, and they're in pain and whatnot, you can roll this machine in, just roll it up to the bedside, boom, and take a look and see what's going on. The heart, it's that fast. The quality of the picture is super dependent on this person, on the tech. A really good ultrasound tech makes all the difference as to whether or not you're going to get great pictures. And those with experience about getting around and getting certain views and understanding where they are in 3D are tremendously valuable. And then you collect data and capture movies and things like that and send it to the physician usually, and they look at it. Sometimes the physician is this person. So if it's a cardiology fellow, it's 10 at night and they're called downstairs because somebody showed up at the ER with chest pain and they're doing an echo, it'll be a physician doing it. Right? You can miniaturize this, as you might imagine, because if you look at the at the technology, the transducer is here. That's some very advanced technology right there, how you make that transducer. And then it's connected basically just to a computer, right? So these things can get really small, right? Computers, it can, like I have one in my pocket. And so you can make ultrasound machines that are very tiny and portable, right? And so that here's a transducer, and you hold this in your hand, and you can go out in the field and do whatever, and get great pictures. So most manufacturers now are making a handheld ultrasound machine. So what does a heart look like? When the tech angles the transducer such that we're looking up under the ribs towards the heart, you can get a really nice view of the long axis of the heart. So this is the left ventricle, this is the mitral valve, left atrium, and so you get a really nice dynamic view of that. And then you can simply rotate the transducer to get other, pictures of other walls of the heart. That's one of the primary views that's looked at. Again, the quality of this picture and its representation of what the heart is highly dependent on whose hand this is, right, and whether or not they know what they're doing. Okay. So look at traditional views. When you present a heart with echocardiography to someone, usually you present the same views each time so that a person that's reading them gets to know what they're looking at. And here's a parasternal view. This is a view of the heart when you're looking through the ribs across the heart like this. And this is the left ventricle, a little bit of the right ventricle here. This is the aorta and the left atrium. And that's what it looks like on the echo. As you can see, the echo falls away pretty quickly as we go to higher angles away from the center line of the transducer. But people get to learn how just to read this and then tilt the plane. And then this is called a long axis 4-chamber view, where you have the right ventricle, the left ventricle, and the left atrium, the right atrium here. And that's what it looks like. And then rotate 90 degrees from this plane to get this, which is a 2-chamber view around the left atrium. And you see another view of the mitral valve, another view of the left atrium and the left ventricle. So with these 3 views, you've pretty well sampled all of the left ventricle to within, 60 degrees or so. And when you're looking at a short axis view with echo, you put the transducer on the patient's chest, try and find a gap through the ribs. If you hit bone, all the sound just comes straight back at you. So you have to get it between the bones, and then it goes down through the spare rib and hits the heart, and you start getting reflections off the heart walls. And so these are called short axis views. They look like donuts, and this is the myocardium here and the valve plane. This is what an abnormal heart looks like. Let me see if this might be a movie. Let's turn that on. Yeah. So looking at static echo images is one thing, but normally they're presented like this, where the heart's beating, because you're getting 15 or 30 images a second, something like that. So here you can watch the actual wall motion and determine whether or not this myocardium is all contracting well. If some of it is not contracting, that's an indication that the person has ischemia, or perhaps they've already had a heart attack and that part of the muscle is already dead, which happens. People come in, and like we had a surgeon came in, and we did a CT or an MRI of the guy's heart, and there's a big infarct there. Not big, but medium-sized infarct. I'm like, did you ever have chest pain? And the last thing, he goes, nah, not really. And so sometimes you get pain, you're like, oh God, and you just push through it, and you have a heart attack, and you move on, right? And you survive. But a chunk of your heart is dead, right? So the tissue distal to where that blockage was dies, and it fibroses over. And we'll see in MRI, you can see that very well. that tissue would also look like an abnormal region on an echo like this. Oops. And then these are really cool. So because you're looking at sound, or listening to sound with your transducer, if your transducer is up here, and you shoot sound waves this way, and they bounce back to your transducer this way, when they hit something that's moving, you'll get a Doppler shift in the frequency of the sound, right? Just like when the bus goes by and it's high frequency, and then it goes, you get low frequency as it's going away. With echo, I know exactly what frequency I'm putting in here, and then if the echo that I hear is up in frequency, then that means that the material that I'm looking at is moving towards me. If it's down, it means it's moving away from me. Right? So you can plot that shift in frequency as a color, and that's called Doppler echocardiography. And so this is the blood in the ventricle. Here's the transducer up here shooting sound waves this way. Left ventricle, you can see that there's a shot of positive going velocity this way. Here, we have a problem, actually, in that there's see that little jet that occurs right here? This is the mitral valve, and that little jet should not be there, right? The mitral valve should close, and you shouldn't see velocity shooting through a closed mitral valve. And so what is happening is the mitral valve is attempting to close, but there's a slight gap, and blood is firing back through the mitral valve in the wrong direction. And so that little blue spike there shows you that regurgitant valve. Any questions on echo? Well, good question is like, how much does it cost? Or how long does an exam take? Or when do you get your first one? When you get your first one, you're usually about 12 weeks old, right? That's when they do your first echo, and you look at the heartbeat of the fetus, right? And then you see this tiny little heart on the echoes goes like that, and then you turn on the sound for the Doppler, and you hear this little, right? Because you're echoing this little thing about this big, but it's got a little heartbeat. Right? So that's when you got your first echo. You all probably had one. I don't know. And then you just keep getting them. Like, I don't know, you have about 6 of them before you're born. And then you wait till you're 55 and you get one after you have a heart attack. Right? So the next thing we'll look at is single photon emission computed tomography, or SPECT. And this is a very interesting imaging technique. It started out imaging cancer, basically. And what you do is you inject an agent into the patient's bloodstream, and it goes all over their body, and this agent is radioactive. So it's emitting radioactivity, right, at a certain energy, right? So there's some, nuclear transition occurring such that a photon comes out with a fairly high energy that's radioactive. So basically you're glowing. If you have the right goggles on, you can see the person's glowing, and they're glowing from where you injected this stuff, right? And if you just have a big old flat detector right on top of the patient, which is how they started this business. In fact, they started it with a single detector and rastered across the patient. But anyway, let's say we have a big detector like this. You inject it in somebody. If they have cancer and you see all of these pockets of glowing lymph nodes, that's absolute indication that cancer has spread, right? And so it's been used for years and years, and it's still the standard way of determining whether or not a cancer is somewhere else in your body rather than just a primary tumor, right? It turns out that over the years, as people worked on this, they found that they could actually measure the amount of radioactivity going in and out of a volume and estimate the blood flow in that volume. And so the heart is for cardiovascular disease, that's a really valuable thing, because you want to know, the patient comes in, they have chest pain. They can have chest pain for multiple reasons. 75% of the time when a patient comes into the ER and they have chest pain, it is not a heart attack. So you don't want to send all those people off to the cath lab, right? You basically want to figure out who's got indigestion and who has a heart attack, right? Or a, pyloric ulcer versus a heart attack. And so what you can do is you can image their heart with this technology and determine if the blood flow is abnormal. Like, is their blood flow low, distal to their main, left anterior descending coronary artery? Is there a spot that they have low blood flow? And that's an indication that they're having a heart attack, and you should send them to the cath lab to get treated. This is the kind of geometry that you would set up to image somebody's heart. The radionuclide is producing photons that are coming out in all directions, right? Essentially just coming out over the whole sphere around the patient. So you'd like to detect them all. So you essentially want to cover the patient with as many detectors as you can. And so here you've got most of it covered, like half of it covered, and you're going to image the patient's heart here. And this detector, what you do is you rotate it around the patient to get views, projections through the patient at different angles. And so this is an example of emission imaging. So it's like the patient themselves is emitting radiation versus transmission imaging. Transmission imaging, we provide the radiation from an external source, shine it through the patient, and the patient casts a shadow, right? And that's transmission imaging, usually. Sometimes you can look at how the radiation deflects off certain things, if you're looking at that as an interaction or reflection. But for the most part, what we're going to look at with X-ray CT and X-ray angiography is pure transmission, just they cast a shadow. Right? SPECT is this form of imaging where we've injected a radiation source into the patient, and the detector will pick up that source and measure the localized intensity of the radiation emission. And that'll be the picture. Just brightness means a lot of intensity from that location, right? Or you can invert the color scale and do darkness. This is what traditional nuclear medicine does. We'll get into some of the details about this, but there's some corrections that you have to make because something in the middle of the patient will look less bright than something at the edge of the patient, because all of the radiation at the middle has to go through the patient, right? And some of that radiation gets absorbed by the patient. So if I have two equal sources, one's in the middle and one's at the edge will look brighter because it's just shining straight at the detector, whereas the one in the middle has to go through a bunch of stuff. So there's a probability that some of that radiation gets absorbed by the patient, right? And so if you don't correct for that, your images look something like this. For a uniform object, you'd get this sort of depression in the middle. And then when you apply a model correction for that, you can normalize that signal such that a uniformly radiating object looks uniform. This is a big problem. And this, you look at it and go, oh, we'll just fix that. This is the main reason SPECT does not work in some people, this phenomenon. Because what happens is if it's a female patient and a breast is in the direction, of a primary view or something like that, you will see a dark spot behind that. And they'll call it a perfusion abnormality in the heart when it wasn't. It was basically just, the preferential angle, the radiation was getting absorbed. Right? So it's a big problem, which is why much of SPECT, and certainly PET now, is done in combination with a CT scan. So instead of a SPECT scanner, you get a SPECT CT scanner. You do a CT image, and then you put them in the SPECT scanner, and you use the CT image to correct for the absorption, of the radiation in the SPECT scanner. And then my argument is that you should look at the CT scan because often in the CT scan, You'll see coronary calcium. You'll see all this other stuff that tells you that patient's sick, regardless of what you see on the SPECT. I'll dig up some examples where the SPECT was normal, and the CT used to correct the SPECT shows this patient's not normal. So anyway, that's just my bias. So the geometry is the following. Has anybody done tomography before? Raise your hand if you've done some kind of tomography imaging before. No? So we're all new to that? Okay. We'll do that. So if I have the patient here, and these are those two detectors that we saw outside that guy in the scanner, we put these sepia down here, and they absorb radiation. And so this detector is basically heavily weighted to looking straight down, right? So at each position here, the photons that I'm going to detect are basically in a straight line along here. Anything that comes from over here and tries to hit this detector, it gets absorbed by these sepia. Okay, it's called an anti-scatter grid. And it sets up a geometry so that the data that I'm obtaining is primarily straight, projections through the patient along straight lines. That makes the reconstruction for the math much easier. Okay, in fact, it makes it possible probably. That's right. So you have a loss in photon counts. So your efficiency goes down. Not all of the radiation that is produced by your injection goes towards making a picture. Some of it gets absorbed by the patient, some of it gets absorbed by this anti-scatter grid, but the stuff that you detect, you can use to reconstruct a picture. And so here's another example of a geometry where you have detection on one side and 180 degrees around you have detection on the other side. You could imagine there could be another detector here. You just try and load up detectors so you catch all the photons that are coming out. And then this whole gantry here rotates, okay? And this section here is probably the CT section, right, of this scanner. Okay, so what we'll look at is stress imaging, and this is a common thing that's done in cardiology. It's done in echo, it's done in SPECT, PET, some MR and CT, not so much CT yet. We'll get there though. And that is you make an image of the patient's heart when they're lying there at rest, and then you stress them, right? Because oftentimes in order to generate symptoms for cardiovascular disease, you have to put a demand on the flow. And so if you get on a bike and you ride the bike, you start getting pain. And so basically you want to image that condition, and you'd like to compare it to the rest condition as a self-normalization for that patient. So this is called stress imaging. It's a bit of a pain in the neck because it takes longer, right? And you have to have a cooperative patient. They have to be able to pedal a bike sometimes, or they have to be able to tolerate a drug that you give them to increase the flow demand. Okay? So if you give somebody a drug called adenosine, all of the distal vessels dilate and the flow demand goes up. And if the stenosis is severe, those vessels dilate, the flow demand goes up, but it can't, make it. And so you get ischemia, and you'll see a positive result on the stress test. So you make an image in that condition. Sometimes in that condition, people develop EKG abnormalities, right? And then if the EKG abnormality is absolutely classic for ischemia, you may not even have to image. You can send them to the cath lab. The problem with that is 50% of the time when the EKG abnormality is absolutely classic and you send them to the cath lab, 50% of the time they're normal. So it's not very specific, right? However, most people that have ischemia will generate that abnormal EKG. So it's sensitive but not specific. It's actually not that sensitive. It's about 75% sensitive. EKG abnormalities. So stress tests, what they look like, if you have slices of the heart And here the orange color represents where a lot of radiation, like high intensity radiation, was coming from that location. That means the blood flow got to that location. So if everything's orange, that means when you injected this stuff in, it went to everywhere in the heart. We're good. If there's a blue chunk so in this guy, in a few slices, you can see part of the wall is missing here. It's not orange. And that shows up in this, it's called a bullseye plot. This orange chunk, or this blue chunk here, that says that ischemia has developed, right? And therefore, this would be called a positive scan, in that there is disease here. Again, this can be caused by a number of other sources, right, than ischemia. It can be caused by shadowing artifact, etc. And so sometimes this imaging technique is about 75% sensitive and about 60% specific. It's not terrific, but it's done all the time, right? Part of the reason it's done all the time is that it's available at the cardiologist. So if you go to a cardiologist in their private practice, they look at your EKG and say, oh, yeah, normal, they can take you in the back and do this stress test right there, right? And so it's done a lot because of that. It's just convenience for the patient. Okay, positron emission tomography is a type of nuclear medicine in which instead of a single photon coming out of the object when you get some nuclear event and radioactive decay, this is a special type of radioactive decay in which a positron is emitted by the substance you've injected into the patient. And a positron is the pair particle for an electron. And so what that positron does, as soon as it's emitted in this radioactive decay, is it meanders around randomly for about a width, like a Gaussian probability of survival of about 2.5 millimeters in the patient. It goes around. And then as soon as it finds an electron, the two of them annihilate and they turn into two photons. And because the angular momentum is conserved in that nuclear interaction, the two photons go in exactly opposite direction, right? And they're 511 MeV photons. They are the equivalent mass of an electron. And a photon is 511 MeV. That's when you look at the energy in that mass. They go out like this. So you have this fantastic opportunity when that happens if you can detect those 511 MeV photons, right? Or it's 0.511, sorry. So the event occurs here, the two photons shoot in opposite directions, right? And if we detect this event and this event, which is the photon hitting the detector, and those events are simultaneous, you know that, okay, I have a positive event, and you know exactly the line upon which that event occurred. So you can draw a very narrow line through the patient. It's like, a string going through the patient. You say that event occurred somewhere along that string, right, in the patient. You don't know how far along that string. You just know it occurred along that string. Okay. So that is a projection, right? You've projected that event, up to that direction. If, for example, these detectors were fast enough, there will be a time delay between this detection and this detection if that event does not occur right at the center, right? If this distance is longer than this distance, this will hit first. So if you can measure in picoseconds, right, you can actually get some idea of how far along that line your event was. And modern CT or PET scanners actually can do that. You think people have been building these damn detectors at CERN and everything for 50 years, right? So those detectors just, measure a whole bunch of activity really fast, right? Because they have particles just going, and they have to measure them all, so they got to measure them really fast, right? So these detectors are capable of that if you buy a high-end system. But even if you don't have a high-end system, you still have a very nice, high-resolution estimate of a projection through the patient and say, there's an event along this line. That's equivalent to a projection that you would get, with X-ray or CT. And you have this detector, and it's just sitting there, right? It's a 360-degree detector. You don't have to rotate it or anything. It just sits there, and you just count up events. It's like, and you wait until you get enough events such that your signal to noise of reconstructing would be fine, right? And there are many ways of reconstructing this data, but one way you could do it is put it into a classic tomography, projection geometry and do back projection. But normally, just a big old least squares fit is done on this data. So this is what a PET CT scanner looks like. The CT part is here, and you make a CT image of the patient, and then you put them on in the PET section and just integrate up your counts, and you use the CT part to do that attenuation correction on your data. Okay? Because the probability of one of those photons being reabsorbed by the patient is not 0. So there's a question there, right? And the good question is, okay, if these photons are getting absorbed by the patient, what does that mean for the patient? So these photons are pretty high energy. So when they hit the patient, what are they hitting? They're hitting a molecule in the patient. And when you hit a molecule with a very high energy photon, what's it do to that molecule? Oftentimes it breaks a bond, It can interact with the nucleus, but most of the time it just mucks with the electron shell and just deposits a ton of energy in the patient, right? And so radiation, the classic thing radiation does that is detrimental to a patient, sunburn is one, right? That's radiation. But it's modifying DNA. So it makes single-strand breaks in DNA, right? So you have a helix like this, and one of the strands on the helix gets busted. And then normally what happens, 999 million out of billion or whatever, comes in and you get a repair. But then sometimes it doesn't get repaired right, and you'll have a mutation. And so high levels of radiation will lead to genetic mutation and will lead to cancer, right? High levels. What happens as you get to lower and lower levels is not really known because it's a very difficult experiment to do, because the rate at which abnormalities occur is really low. And so it's hard to know what happens down there. So anyway, that's dose, right? So when we're using radiation, SPECT, PET, X-ray imaging, we're using high energy photons, higher than light, right? They're visible light, and they can do damage to chemistry, chemicals in your body. So the one other downside about using PET is that you need in your facility a small particle accelerator, right? It's called a cyclotron, and basically you have to spin up particles to a high enough energy and make collisions such that you create an element that has this positron emission capability. And it usually has a half-life of hours, sometimes minutes, depending on which element it is. And so you need it on site. And so they take the sample, take it over to the PET scanner, and inject it in the patient right away, right? So that increases the cost of doing this by, $1.5 million or something for your cyclotron. And you need people who are skilled in the art of working with materials from a cyclotron in order to run your facility. So it becomes more expensive. So we have PET scanners here CT PET scanners and stuff. When you drive by the Jacobs Medical Center, they're mostly associated with the Moores Cancer Center. There's a whole building, where they've set it up to do this for cancer. It's pretty well universally done. So the cool thing about PET is the spatial resolution is much better than SPECT. Because of that detection capability, we didn't have to use those septa to just get photons on a specific line. We can look at all the photons because we have the matching photon for the coincident event, and that's the thing that does our putting all the data on one line, and so you can look at all the darn photons basically. And so here's the CT of a patient, and this is the CT with the PET data mapped onto the CT. So it looks to me like this person, if their septum goes up here, they have, a flow deficit in their, right at the base of their septum. If the septum finishes here, they don't. So you have to look at the actual, morphology data in the CT to determine whether or not, you're looking at something abnormal. But you can see it's really nice resolution and high sensitivity. If you had a little dark spot right there, you would just say, okay, that's a blood flow deficit, and this person is positive for cardiovascular disease. So that's PET. We'll look at a chart of dose versus, for each imaging technique. But basically, SPECT is probably the highest, then PET, and then CT. Well, no, actually, SPECT, PET, angiography most of the time because you're under the thing for a long time, and then CT. So computed tomography, this is a modern day CT scanner here. And the thing that makes it a modern day scanner is it's pretty thick in that nowadays they take a traditional CT scanner and they stack maybe 256 of them on top of each other. So you have 256 rows of detectors in the Z direction, in this direction. So you can get 256 slices simultaneously. That's how this huge speed increase occurred in CT. Is the vendors just bit the bullet and said, okay, we're just going to keep making these detectors bigger and bigger. It's a lot of data to get out. This is a whole bunch of interesting engineering problems to solve to make that happen. This is a Toshiba scanner. It actually has 320 detectors in Z and about 1,000 in the other direction. So this guy's getting hooked up to an EKG monitor. This is an injector, so you're going to inject X-ray contrast into the patient and then dynamically image after that injection has occurred, so you can see the contrast between the vessels and the background. The EKG is used in order to time the acquisition of your data to the heartbeat. So if you want a specific phase inside the heartbeat, say at end diastole, you can just take the data there, or you can take the data when the heart's maximally contracted at end systole, or you can take one whole heartbeat. But you use the EKG to determine that. And that's about it. So what is not shown is usually there's a line going into the patient's, what vein is this? Decubitus vein here? Who knows what vein that is? I can't remember. So you put a line in there and you inject the contrast through that vein. And so the contrast enters the heart by going up the arm and along this clavicle vein and then into the superior vena cava, down into the right atrium, into the right heart, to your lungs, back to your heart, okay? And then illuminates the arteries from there. So this is a moving picture of a modern GE CT scanner. The gantry itself rotates now at 280 milliseconds per 360 degrees. All of the mechanics is set to go for 200 milliseconds for 360 degrees. Let's pause this for a sec. Here we go. This at the top of the picture here, top of the frame, is the X-ray tube. It's producing X-rays continuously as the gantry is rotating around the patient to get views from different angles. This is a voltage source for the X-ray tube, and this voltage source actually can flicker between two voltages, say between 140 kilovolts and 80 kilovolts, and it'll flicker between those two voltages to make X-rays of different energy that go through the patient, and those X-rays strobe through the patient. You can make two different pictures. One at 140 kilovolt X-ray and one at 80. The shadow of the patient looks different with those two energies, right? The geometry of the detector is here is basically in the middle of the scanner. The beam is 160 millimeters wide in the Z direction, and so you can fit an entire heart inside this volume, right? And so the heart would be in the middle here, and then its shadow would be projected onto this array, which is longer than 160 millimeters, obviously, down here. But there's 256 slices this way and about 1,000 detectors that way. And you're acquiring data usually at about 800 pictures per 360-degree rotation. That's classically sort of the rate at which you're taking this data. You continuously integrate up the photon counts, the shadow, as you're rotating. And then you page that data out and then take it for another delta T and take 800 so that you get 800 in a view. This scanner is capable of doing 2,400 pictures per rotation, but most are not. Most do about 800. So that's a lot of data to strobe out. You know, these about 16 bits. And so it's 1024 by 256, 16 bits, strobing out at that rate. It comes out over wireless, or sometimes they have brushes on the gantry here where the electrical signals come out over brushes. They obviously can't come out over cables, right? Because the cables, this thing is spinning like this, and so you can't spin the cables up. Early CT scanners, there was a cable, and you had to spin it one way and then spin it back, right? And that's how you imaged. You went one way in the back because of the cables. Big, technological step when you could spin the thing in one direction and just keep it going. All of a sudden, you could spin it many times faster, so your data rate went up. And it led to things like helical scanning, where you got the thing spinning and then you just push the patient through and you get your data in a big helix around the volume. Right? So for us, for doing the heart, usually it is not helical scanning. Usually we just put the scanner at one location that projects a shadow of the heart onto this detector and then take data in a rotation. The data you need for CT is essentially about half a rotation plus a little bit. So at 280 milliseconds, that means we were about 140 milliseconds to get the data we need for a full 3D volume. That's why it's fast, right? And so these are data from a scanner that has a special detector. And you can see this is the left atrium, this is the aorta. These bright spots here are coronary arteries going down the surface of the heart. And this is the right coronary artery here. Its trajectory is down through the back here of the heart. There's a vessel there, that's the left anterior descending. And there's some features that are very interesting that I'll stop and show you in this. We can stop it here. Okay. Oops, my bad. Yeah. This is the aorta, okay? And the coronary vessels come off of the root of the aorta. So this is the left main coronary artery coming out here. And this is the patient's chest. lungs. So we're looking at their heart, and we're basically looking from the patient's feet up, and it's a single slice. This slice, for this scanner, is a bit special. This slice is 250 microns thick. It's very, very thin, right? And you can see the reason that there's bright signal here in the descending aorta, the ascending aorta, the left atrium, is because we've injected contrast into the patient. And we've timed this acquisition such that that contrast is still inside the left part of the heart. So it gives us this bright signal. And it's also in these vessels. So as I move up and down, and I can track the trajectory of those vessels, right? There's the left main, and I go down, and here's, the left segment of the coronary artery. Now that thing right there, that little dot, is a piece of coronary calcium. And so that is indicative of growing coronary lesions or narrowing of your coronary artery. It's something that goes along with the lesions. It's called coronary calcium. And we can detect it in very small amounts with images like this. And so this person, who's a normal 52-year-old or something, 55-year-old, there's another little piece of coronary calcium. So there's no huge concern here because the vessel itself is wide open. But the concern is this person is growing lesions, right? So we know where this ends. They're progressing down this, coronary artery disease development. And so as a screening technique, you can tell this person, hey, you should go on a statin, which is a drug that basically lowers your cholesterol, and it slows down the development of these lesions. And this is what that data set would look like in 3D. So here's basically the right coronary artery coming out of the aorta. This is the left system here. Let's go back. Just pause it here. Right, so this is the left main, and then it breaks off into the left anterior descending coronary artery down to the apex of the heart. And then this is the circumflex going around the back of the heart. So if you have a lesion up here, it's bad news because everything distal to that, if that lesion for whatever reason closes off acutely, then the blood flow goes out, a whole chunk of your heart is missing blood, and usually it winds up with a massive heart attack in that case. So this is CT data. I find it absolutely remarkable. I've been doing cardiac imaging for a long time. I still find this picture remarkable, right? That you can actually do this in a single heartbeat, or a fraction of a heartbeat. In 150 milliseconds, you make this picture. It's crazy that can happen. If you look at individual projections of those vessels, which a lot of cardiologists, radiologists, when they're reading these scans, will look at. So here's the left ventricle, the root of the aorta, and there's the right coronary artery projected. So this is the slab through the patient where you project the maximum intensity onto the outside of the slab, and you can see the vessel looks fine, doesn't have any stenoses or anything like that. Here's another picture of don't know which vessel that is. Here's the right coronary coming out here. This is the left going into the left anterior descending coronary artery there. So you get beautiful pictures of the coronary vessels with CT. The negative predictive value of a coronary CT, which means if you are negative, that means if you're normal, well, let's put it the other way. You come in, you get a scan, you look at the data. If that data shows that there is no lesion in there, and you say, oh, this patient's normal, 99% of the time you're correct. It's ridiculous, negative predictive value, right? So for a hospital, when a patient comes into the ER and they have chest pain, if you do one of these and their coronaries are normal, it is not a heart attack. And you're right 99% of the time. Unlike SPECT, where you're right about 50% of the time, or EKG, where you're right about 50% of the time. Right? This really nails it. And so it's a very strong imaging technique to put up front, yeah?
So the reason they don't do this every time is just a cost thing, essentially?
It is, well, it's not a cost thing because this is cheaper than SPECT. it is a business thing. So CT has not really been adopted by cardiology in this country due to the fact that most of the time they don't run the CT scanner. Most of the time they would have to ask for the CT to be done outside, and most of the time the health insurance provider gives them a rough time about it, and so they stop doing it. What they can do is just send them to their own SPECT scan or their own echo, and then they don't get any pushback, any problem, right? In England, like when they did the studies to investigate the sensitivity and specificity of this, the National Health Service put in place a rule now that if you go to an ER and you have chest pain, they don't work you up for heart disease, they don't look at your risk factors, they don't look at anything, they take a CT because they can just get the answer right away and it's cheap, right? The problem with it being cheap in this country is that who makes any money? If it's cheap, I can't charge much for it, right? So it's this country, the healthcare system is like a profit business, and so you want to do procedures that gives you a bottom line, right? You don't want procedures that basically give you $4 of net profit. But in the National Health Service, it's a cost, so you keep costs low, right? So it's an interesting conundrum. Health insurance companies would benefit from it. And they're starting to figure that out at this point. And so now health insurance companies are starting to approve CT, and also they're basically approving it with this ancillary test that determines the significance of the lesion, and we'll look at that later. It's a very interesting dynamic, right? We'll also look at a paper that tested the sensitivity and specificity of CT versus SPECT, and it was just a rout, right? The CT crushed it. So here's what a stenosis looks like. So you have a vessel coming down here. The vessel kind of disappears and then continues. Here, this is a narrowing of a vessel, and then when you look at it on cath, you get the same narrowing here. So it's a pretty accurate technique. This is a CT scan of a the circumflex vessel. You see how it's wide here, then it gets narrow, then it gets wide again? That's a classic picture of a lesion. It's like, oh, I got this narrowing. You look at it from the orthogonal view, and you get the same narrowing here. And then when we look at it, if we cut the lesion along here and look at it en face, you see the net diameter of that lesion. However, nobody does this. Nobody measures that diameter and says, oh, the lesion, the vessel went from 4 millimeters down to 2 millimeters and back to 4 millimeters. Nobody does that. And the reason is that nobody really understands the precise relationship between this signal, which is a little blurry, right? It's a little blurred. The relationship between that signal and the true size of the underlying object. Because it's right down at the spatial resolution of the imaging device. It's down at the point spread function of the imaging device. So when you're working down in that level, you have to put in some modeling and all of this kind of stuff. So very few people actually do quantitative measurements down there. The way, in fact, the Society of Cardiac Computed Tomography, their recommendation for how you learn how to read these is you just read 1,000 and you get good at it. And so you are an AI engine. You just say, oh, I would call that lesion significant. And then you get feedback immediately. Was that significant? Nope, that one wasn't significant. And you learn how to do it. And it turns out what the radiologists and cardiologists are doing is they're looking at the brightness of the lesion. They won't tell you that. They don't actually know that's what they're doing. But they're actually looking at the relative brightness of the lesion to determine, did it get narrow or did it, to a critical amount or not. It's a fascinating, we're working on this now as a research topic, and so to quantify that. So cardiac MR is, I did this for 25 years. It's awesome. This is a magnet, 1.5 Tesla, 3 Tesla, 10,000, 20,000 times the Earth's magnetic field. Very, very high magnetic field. If you were standing next to this young woman here and you had like a pipe wrench in your hand, that pipe wrench would not be in your hand for very long. There is absolutely no way you can hold on to it. It's just the strongest damn force you've ever felt. And then it goes bang, and it goes into the magnet at great velocity, sticks to the side, and then you have to go in there, click something on, anchor a winch to the wall, and winch that mother out of there, right? And it's just it's like thousands of pounds, right? And so you can winch it out sometimes. Sometimes you can't. You gotta crash the magnet, quench the field, and then you're in big trouble. So the major hazard of MR is flying objects, flying metallic objects. I don't know, about 5 fatalities maybe over the whole history of MR. It's not that many, but it's enough to get your attention. Like an oxygen bottle brought in on a patient gurney, right? If the patient's in the scanner and somebody goes, oh, let's go get the patient, they bring the gurney in, the bottle's there. Not a good plan, right? Because the bottle flies in and the patient's in there. We had a bottle fly in, but there was nobody in it. It just destroyed the head coil. Just all this stuff all over the place. It hit the valve, right? Snapped the valve off, and the full bottle evacuated. Made an incredible noise, right? But it stayed perfectly still. It's like, whoa. Anyway, so this is a surface coil, it's called, and we're going to receive RF energy from the patient from the surface coil after transmitting RF energy into the patient in order to stimulate an emission of RF energy, and it's through nuclear magnetic resonance. And you tie a EKG to a patient, and then you can essentially acquire data in sync with the heartbeat, and then you get these fantastic looking data sets, right? Where the white stuff, this is without any contrast on board, just the white stuff is blood. Due to its natural NMR relaxation times, the contrast comes up. This donut looking object is the left ventricle, and you can see absolutely in great detail the muscle contraction locally, right? So this data here would have been taken with maybe 12 or 16 heartbeats. And so you acquire data over the 16 heartbeats. The patient holds their breath. You can see they're not moving, right? So their breath is held, and you acquire that data. It's spectacular when it works. You can image in any plane you want, and you can program it using some of the planes you've already imaged. You just like cut a line through that plane and get this, which is an orthogonal view. So you get the left atrium and the left ventricle here, and you can see the swirling of the blood here, and that's due to the sort of differential saturation of the blood from the RF pulses. You can use that signal. In the orthogonal, you can see here the valve here. You get a nice picture of how the valves, these are the coronaries up here. That looks like a vein, actually. It's so big. Oh, that's the vein there. That's part of the coronary artery. You can also mark the tissue with RF pulses such that you essentially eliminate signal from selected regions in the patient. And in this case, we chose to do a Vegematic kind of, like a chunk. Well, you guys never have seen one of those, but like parallel planes of signal gets eliminated so that you can see how precisely how locally the ventricle is contracting, and you can like play a movie and measure the strain dynamically, right? This is that taken to an extreme where you put a very high resolution Cartesian grid on the heart and then watch that Cartesian grid deform over time to get absolute precise measurements on like 3 millimeter cubes of how the heart's contracting. This takes a lot of heartbeats. This doesn't come for free, right? The signal to noise and the spatial resolution here, the reason it looks so great is many heartbeats that were identical went into making this data, right? Probably about 30 seconds per slice or something like that. It was a lot. But I love it. It looks great, right? It's like, it is now the gold standard for measuring like cardiac function. And then you get the MR, you can measure all sorts of things like bright tissue where you have infarcts. And then, there's this flow video. So, forgetting about the crazy music. So check that out. So this is basically tracking particles when you measure the velocity vector as a function of position and time with MR data. And then you release particles into that velocity field, and you can generate these customized sort of flow particle tracking maps for each patient. Right? So not that that's used that often for patients, but in some cases where you have some very strange geometry, particularly in kids who have sort of congenital heart defects, and you're trying to figure out where things are going, you can make pictures like this. So it's pretty cool. All right, I think we'll go back here. And the last thing is X-rays, angiography. This is an angio suite. This is what it looks like most of the time when something exciting is going on. All the physicians are standing around. They're projecting X-rays through the patient and looking at the screen in real time. While they project those X-rays, they inject dye, and they see the projection of the contrast dye in the patient. And then that picture looks something like this. Right? So the cardiologist put this catheter up in here, plugged it into the coronary artery, and injected dye into the coronary artery. So now you see terrific contrast of the artery itself, and you can measure precisely where the abnormalities are. This is where you wind up if everything says, oh, this person is having a heart attack. They actually have cardiovascular disease. We need to go in and fix a vessel. You wind up here, and they either put a stent in or decide to send you to surgery. Okay, and then these are all just different. And we'll look at some of the details of that as we look at X-ray angiography. Okay.